Good evening, everyone. Thank you so much for joining the Heart Failure Society of America's Heart Failure Patient and Caregiver webinar series on cardiac amyloidosis, the heart of the matter. My name is Dr. Brittany Clayborne. I am the chairperson for the Heart Failure Society of America's Patient Committee, and I'm so glad that you guys have chosen to join us today. Today we will be talking about cardiac amyloidosis. And before we start, we want to give a big thank you to our sponsors, AstraZeneca, BridgeBio, Intellia Therapeutics, and Pfizer. So our program today consists of a couple of amazing people telling us about this really complicated disease, but they're going to make it sound super simple. The first will be a heart failure specialist, Dr. Joban Vaishnav, who will discuss the clinical aspects of cardiac amyloidosis, followed by a heart failure patient speaker talking about his journey with the disease. We will take a few questions and answers from the questions section to present to the speakers at the end of both segments. There is a question tab on the far left-hand side of your screen. So if you have questions, please feel free to type them in there, and we will moderate them at the end of the presentation. Dr. Joban Vaishnav is an advanced heart failure and transplant cardiologist and director of the Johns Hopkins Comprehensive Amyloidosis Center. And the next voice that you hear will be hers. Welcome, Dr. Vaishnav.
Thank you so much, Brittany, and thank you to HFSA for hosting this event, and thank you to everyone for joining us this evening. So as Brittany mentioned, I am a heart failure transplant cardiologist at Johns Hopkins and specialize in cardiac amyloidosis, which is the topic at hand today. For our talk, I wanted to cover a few basic tenets, specifically what is cardiac amyloidosis and how is it diagnosed. I hope to spend the majority of the talk talking about how is amyloidosis treated, both from a symptomatic and disease-modifying standpoint currently, and then what does the future hold, and we'll end with some resources for patients and caregivers. So jumping into the topic at hand, cardiac amyloidosis and what it actually is. Many of you may know this if diagnosed, but amyloidosis is really a broad term for diseases that result from protein misfolding. And these proteins become incapable of being cleared from the body, and as such stick to vital organs that then lead to their dysfunction. So in the case of cardiac amyloidosis, that protein is sticking to the heart muscle and leading to injury and damage. And shown here are two pathology specimens from a heart biopsy. And I'll highlight the specimen on both the left and the right. The left, you can see this salmon pink deposition. That is actually the amyloid in the heart, surrounding the heart muscle. And then on the right, you can see the amyloid protein lighting up as apple green with Congo red staining, which is classic for this condition as well. So there are many types of proteins that can cause amyloidosis. However, I highlight here the major proteins that cause cardiac amyloidosis, specifically light chain, known as AL amyloidosis, and transthyretin, known as TTR amyloidosis. Light chain amyloidosis happens when there is abnormal or clonal plasma cell production from the bone marrow, which a component of those are light chains that then can misfold and cause the amyloid. TTR is a protein that's produced from the liver, and we'll go through that cascade a little bit later. So it's predominantly produced in the liver as well as the brain and the eye, and can misfold and cause amyloid. TTR specifically can be caused by one of two processes. One is either related to a genetic mutation known as hereditary TTR, or alternatively, this could be an age-related process known as wild-type TTR, previously senile TTR, and this is not hereditary. So symptoms of amyloidosis are important to recognize, but importantly, often go under-recognized. They can be very non-specific in the beginning. And I think this does contribute to the underdiagnosis and underappreciation of this condition. But when amyloid deposits in the heart, the main symptoms are those of congestive heart failure. So specifically shortness of breath, fatigue, swelling, and weight gain, or in fact, weight loss. And you can appreciate why those symptoms may happen by looking at these images here. So in amyloid, when the protein deposits, the heart muscle becomes thick and stiff, and that heart cavity becomes quite small. And that heart cavity then becomes very prone to fluid buildup and these symptoms of congestive heart failure. So this is a cartoon. You can see a cartoon depicting it. And then there's also echocardiogram images showing this as well, thickening across the heart muscle, a very small heart cavity size as well. There are important non-cardiac symptoms of amyloidosis, as this is a systemic process and can deposit in other parts of the body. And there's overlap with AL and TTR, but I did split it by disease. So important non-cardiac symptoms of light chain amyloidosis can include bruising around the eyes, known as periorbital purpura, as well as enlargement in the tongue, macroglossia. The heart is the most common organ involved, though the kidney is right up there as well. And so you can have chronic kidney disease or protein spillage in your kidneys, as well as GI symptoms. And neuropathy can occur either related to the condition itself, or some of the treatments can cause neuropathy in light chain amyloidosis. Now, important non-cardiac symptoms of TTR amyloidosis include polyneuropathy, and this is specifically the case with hereditary disease. There can often be overlap with cardiac and neuropathy, as well as autonomic neuropathy. So dizziness or lightheadedness when standing is common. And then there are also a lot of orthopedic manifestations that can happen well before the onset of heart disease. So many of us may have heard of these red flag symptoms, but bilateral carpal tunnel syndrome would be one, lumbar spinal stenosis, as well as trigger finger are common non-cardiac manifestations of TTR. So jumping next into how amyloidosis is diagnosed, I truly think the most challenging aspect of diagnosis is to have it be suspected. So it must be suspected by a healthcare provider for it to be worked up further. And it's often suspected with a combination of symptoms, including heart failure, perhaps abnormal heart rhythm, such as atrial fibrillation, with or without what we call conduction disease, so blockages in the rhythm system. The non-cardiac symptoms I mentioned may lead to suspicion, as well as family history and important echocardiographic findings, such as thickening of the heart muscle. Once it's suspected, it's very important to expeditiously rule out light chain disease, which tends to be more rapidly progressive compared to TTR. And light chain disease can be ruled out with a combination of blood work and urine testing with good certainty. And so that is the first step in sort of the diagnostic algorithm. If those tests for light chains are normal, we go on to do a nuclear scintigraphy scan, which has thankfully replaced the need for heart biopsy in the majority of TTR patients and allowed for a non-invasive diagnosis. If the light chain testing is abnormal, we are still obligated to do a tissue biopsy, oftentimes a heart biopsy. And so shown here are images of a PYP scan, which many of you in the audience may have had. And the scan basically, the radio tracer binds the TTR fibril and leads to the uptake. And so grade 0 is what we consider a normal scan, contrasted to a grade 2 or 3 scan, which you can see there's clear uptake in the heart that's greater than the bone nearby. And so that's consistent with TTR amyloidosis. It's very important to do genetic testing once TTR is confirmed, either with PYP or biopsy, because as you saw, a component of TTR is in fact hereditary. And that could guide which symptoms we would expect one to have, ranging from neurologic, mixed, or primary cardiac disease. And importantly, there are more medications approved for hereditary polyneuropathy at this point compared to cardiomyopathy. So it's important to get that testing done. It would guide treatment. Of course, it informs familial risk. And lastly, can certainly assist with reproductive planning as well. So I want to move next to the bulk of the talk, which is treatment of cardiac amyloidosis. And I tend to split this into two big umbrellas. The first one being symptoms. How do we get patients feeling better? The bulk of it is treatment of congestive heart failure, but amyloidosis is a special type of heart failure that is harder to treat because there is a narrower window for what we call over or under diuresis, or too little or too much fluid. And that's related to that thick, stiff, small heart cavity that I depicted earlier. So this is really what we're balancing. To treat congestion, we lean heavily into loop diuretics with mineralocorticoid receptor antagonists, and kind of the new kid on the block that is being considered more and more is our SGLT2 inhibitors, which help augment diuresis in amyloidosis. There are certain medications to avoid. What I'll highlight are those medications that are often started prior to an amyloidosis diagnosis, specifically heart failure guideline-directed medical therapy. So these are medications that have been shown to consistently improve survival in non-amyloid heart failure, but not consistently in amyloid heart failure, and could make patients feel worse. So these include beta blockers, ACE inhibitors, and angiotensin receptor antagonists, as well as Entresto. So these are medications that I'm often considering de-escalating when I meet patients, especially if that blood pressure is running very low. And the second big umbrella of treatment is what I consider disease-modifying therapy. How do we prevent this protein from further depositing and causing further organ damage? Disease-modifying treatment varies dramatically whether or not you have AL or TTR, which is why it's incredibly important to get that correct diagnosis up front. For AL amyloidosis, disease-modifying treatment is guided by hematology oncology, and we use a combination of chemotherapy. I list some of the agents here. Psy.D, for example, is a common regimen with immunotherapy. So daratumumab is a monoclonal antibody that is shown to significantly improve outcomes in AL amyloidosis in achieving hematologic remission. So often we're using a combo of chemo and immunotherapy. Some patients may undergo or may be considered for stem cell transplant. So stem cell transplant effectively replaces the bone marrow with healthy cells rather than these plasma cells that are being produced abnormally. And whether or not one needs a stem cell transplant is very case by case and may even vary by the center that you're being seen at. I list here some criteria that would deem someone eligible, broadly speaking, for stem cell transplant, only to say that there are a lot of factors that may make stem cell transplant too high risk: elderly age or severe heart failure, to name a few. So what may we expect for the future of treatment in AL amyloidosis? Well, the medications that are most actively being studied are the monoclonal antibodies that essentially activate the immune system to destroy the amyloid fibrils. And there are two I list here, CAEL-101 and bertemimab, that are in phase 3 study in folks with heart failure. So I suspect and hope that we will have more information on these drugs in the future once these trials are complete. I'm going to skip this slide for time, but we can talk about it in the Q&A. And I want to move on to treatment of TTR amyloidosis, disease-modifying treatment. And to understand disease-modifying treatment, we really have to understand the amyloid cascade. How does TTR form? Well, as I mentioned, the bulk of it is produced in the liver. Recognize that the liver is usually healthy in TTR amyloid patients, but the protein that's being produced is abnormal. In its healthy form, TTR is a tetramer, a four-leaf clover, and is a transport protein. It has function in our body, in everyone's body. However, in the case of amyloid, whether it's related to the genetic variant or age, that tetramer breaks down into these monomers and then goes on to form the sticky amyloid fibrils that deposit in the organs. And so very thankfully, we have medications that target, as you can see, almost every aspect of the amyloid cascade, starting here with gene silencers. So these are medications that aim to shut down the protein production. Moving along to stabilizers, medications that aim to stabilize the healthy version of the protein. And then most recently, medications called anti-amyloid therapies or depleters that aim to remove the amyloid fibrils. So I'm also going to skip this for time, though I'll highlight what our goals are. We really aim to improve symptoms, slow or halt disease progression, though in the future, hopefully reverse disease progression, and then prevent hospitalization and maximize lifespan. So jumping into specific medications, starting with tafamidis, which is right now, it was the first and it's currently the only FDA-approved medication for TTR-related heart failure. And it is the class stabilizer, so it binds to the stable, healthy form of the TTR, thereby preventing the breakdown. Tafamidis was kind of expeditiously FDA approved following the ATTR trial, which showed a significant reduction in death and heart failure hospitalization. And that trial went out to 30 months, but we do have long-term extension data out to 5 years showing sustained benefit. So now we have an extrapolated survival on average of more than 5 years if you were on drug, compared to close to 3 years if you were treated with placebo. And this graphic here just depicts that your risk of dying was far less, or there was a greater benefit if you were treated with less severe heart failure. So take home being earlier, the better with stabilizers. The next medication I expect to be FDA approved for TTR amyloidosis is this here, acoramidis. It is also a stabilizer, but works with a slightly different mechanism, which is it mimics a super stabilizer gene mutation known as T119M. So a unique mechanism. And acoramidis was studied in the ATTRibute-CM trial. And I show here some of the positive benefits. This was a positive trial with benefit in its combined endpoint. And these are what I depict. So there was less of a rise in proBNP, less of a decline in what we call the 6-minute walk distance and symptoms, and then an improvement in the serum TTR level. So again, this is under FDA review, and we are hopeful for approval soon. I'll note that the reduction in mortality wasn't as dramatic as that which we saw in the ATTR trial, but really the hypothesis or thought there is that the placebo group, the comparator group, was simply healthier, because between the two trials, thankfully, we've detected amyloid sooner, and so that placebo group was healthier. And that is really the suspicion rather than this medication being inferior. I'll next move into silencers. These are medications by different mechanisms that disrupt the production of the protein by RNA interference. Importantly, silencers, specifically these here, patisiran and vutrisiran, are FDA approved for hereditary polyneuropathy already. So many patients with amyloid may in fact be on these medications. Patisiran is administered IV and was studied in a cardiac population in Apollo B. And it was a positive trial, but the FDA recently did not approve patisiran for treatment of cardiac disease, citing that the endpoint was not dramatic enough, or the improvement was not dramatic enough. That said, we have a newer version of patisiran called vutrisiran, which is subcutaneous rather than IV and dosed less frequently. And that was studied in the Helios B trial. And we expect those results pretty soon. So more to come on vutrisiran for treatment of cardiomyopathy. The next silencer I'll mention is eplontersen, also FDA approved for polyneuropathy. And again, it shuts down the production from the liver. So there is about an 80% depletion of TTR compared to placebo. And also, this is administered subcutaneously. And the thing to note, the thing to take on, this was studied in the largest trial to date, about 1,400 patients. So many of you may have been in this trial. And so we do expect results sometime next year on the efficacy of this treatment. So a silencer that's exciting and under investigation is the NTLA 2001, which utilizes the CRISPR-Cas9 technology to edit TTR gene production. So basically, it's an IV infusion. It gets taken up by the liver, and it disrupts it, it edits the TTR gene and makes our body sort of dispose of it. And it is effective for both wild type and hereditary TTR. Compared to the other silencers I showed, the unique things about NTLA is that it is thought to lead to more potent TTR reduction. So you can see I mentioned 80% for the other agents versus 90% in serum TTR level for this medication, and also more sustained. So one dose of this medication had benefit or serum TTR reduction out to 2 years. So that's almost permanent at this point. And so this therapy is being studied in the Magnitude trial, which is ongoing, a phase 3 trial, and it should be it's a large international trial that we're excited for. So the last class of medications I'll mention, which are essentially all under investigation, are the depleters. And I highlight here the medication by Alexion. And depleters are, generally speaking, monoclonal antibodies that, again, activate the immune system, that bind TTR, and then your body clears these fibrils. And these are medications that have the potential to reduce heart damage or reverse heart damage. So the Alexion medication has been studied in phase 1 on a phase 1 trial, and it's a interesting graphic here, impressive graphic, I should say, showing that PYP uptake was dramatically reduced with treatment of this medication. And so this medication is also being studied in the phase 3 trial that is ongoing. And then 2 other depleters that I highlight that are being investigated in various phases. The unique one I'll mention is ATO2, which is actually pan-amyloid depletion. So it is effective for both TTR and AL, and that is the capacity that it's being studied. And so these are both in phase 1 or phase 1, phase 2 trials. So it'll be a little bit longer till we get that phase 3 data, but should be coming in the future. So that was kind of a whirlwind tour of the current and future treatments. I do think clinical trials are a great way to both contribute to the field, but also to potentially get medications that are only going to be available down the road. I'll highlight also that amyloid is a multidisciplinary condition, and we do tend to take a multidisciplinary approach and work with multiple other specialists to treat this disease. And as many answers as we have are there questions for the future, which we can talk about in the Q&A. And I just list some of them here for thought. And I think hopefully, we will continue to get answers to these very important questions. And then lastly, I just want to highlight some resources for our patients and caregivers living with amyloidosis. The amyloidosis support groups, Amyloidosis Research Consortium, Amyloidosis Foundation, and then you'll hear a little bit from our patient advocate, Sean, about the Amyloidosis Speakers Bureau as well. Thank you.
Joban, that was amazing, as always. There are already plenty of questions pouring in, and we will get to those questions after we are done with our patient advocate. So if you have questions, please do not hesitate to put them into the submit a question box on the lower left-hand side of your screen, and we will answer those as soon as Sean is done. So I will be introducing now Sean Riley, who resides in New Hampshire and is a retired nuclear reactor operations training instructor and professor of nuclear engineering technology. Sean was diagnosed with the rare disease of hereditary amyloidosis in March of 2019, and I'm super excited to hear his story. Welcome, Sean. Thank you so much for joining us.
Well, thank you very much. It's great to be here. A little bit about myself. I grew up in Greater Boston. You may pick up on my wicked good Boston accent. Like Brittany said, I spent over 30 years professionally as a nuclear reactor operator and nuclear reactor operator training instructor. My personal life, I grew up a reasonably athletic person, and this kind of plays a part in my story. I played ice hockey up through my childhood and continued to do so in my adult years in men's leagues, and to the point where I couldn't play anymore because of the disease symptoms. Also, I was a fairly big, strong person. I spent a fair amount of time at the gym lifting weights, and you know, it's pretty rugged with tasks around the house and whatnot. So a fairly healthy, robust person. I was diagnosed in March of 2019. That was after about a 6 or 7 year journey to diagnosis. So my story starts, I was about 48 years old. Again, this is 6 to 7 years prior to my diagnosis. I was starting to experience pain in both of my hands, which kind of manifested itself as carpal tunnel syndrome. So I had both hands operated on for carpal tunnel surgery. I didn't think much of it at the time because my job required a lot of handwriting and typing and whatnot. And so I just figured it was a typical type of carpal tunnel cause that we all hear of. Little did I know at the time, and little did the hand surgeon know, but that was the initial onset or the initial symptoms of the hereditary amyloidosis starting to build in. Around the same time, I started experiencing some numbness on my left foot. Now, I had previously had vascular surgery on my left foot, so I attributed that to perhaps some nerve damage done by the surgery. But that wasn't the case. That was actually the peripheral neuropathy from the disease starting to work its way up from my extremities. I now have peripheral neuropathy all the way up both legs up through my hips, and also in both the hands and arms up through my elbow. Fast forward about a year, and I experienced, I was sitting at home doing work at my desk. I stood up, I was experiencing some uneasiness in my chest. I thought I was having a heart attack. It felt like I was going to faint. I was actually taken to the hospital by ambulance. And these are all local hospitals in New Hampshire where I lived at the time. In emergency service, they did the normal workup that you would do for a heart event. All the blood work came back. They couldn't see anything. So they pretty much stabilized me and sent me on my way. Again, little did we know at the time, but what I was actually experiencing was orthostatic hypotension, an acute drop in my heart, my blood pressure, and that was due to the autoneuropathic symptoms starting to kick in from the disease. Fast forward another year or so, and I started experiencing gastrointestinal problems, both on my upper and lower GI tract. The local gastroenterologist performed scopes of my esophagus and whatnot, and based on their visual observations, they couldn't see anything. Again, little did we know, had they taken a biopsy and tested it, they probably would have found amyloid in the GI tissues and in the nerve cells controlling the GI tract. Fast forward another year, cardiac episode number 2. Brought to the hospital. This time I was at work. I started experiencing those same type symptoms I had experienced prior, an uneasiness in my chest, and it felt like that I was going to faint. I was taken to the same local hospital here in New Hampshire. They did the same workup, blood work and whatnot in emergency service. They couldn't find anything. This time the cardiologist decided to order a series of tests, including an angiograph. About a week or so later, he called me and I went into his office, and he actually showed me the results of the test, and he said, "Sean, what we see here is not only is your heart healthy, but it's actually robust looking and looks like an athlete's heart." And he actually recommended that I could go home and train for the Boston Marathon. I'm glad I didn't heed his advice, because what he was actually seeing was enlargement of the heart tissue due to the amyloid building up in the heart. From that point forward, up until about 2018, so we're talking about 2016 to 2018, I lost about 60 to 70 pounds of weight. We didn't know what was going on. My primary care physician ordered a CT scan to see if there was any type of malignancy or whatnot. They couldn't see anything. So here's where my story takes an interesting turn. In 2018, I was eligible for a retirement package from the company that I've worked at for 30 years. So I was approached by a professional headhunter who asked if I was interested in going over to Abu Dhabi in the United Arab Emirates to teach engineering over there at a power plant that they were building. So I did that. And when I arrived in Abu Dhabi in June of 2018, I wasn't there a week. And I once again, this time I experienced that uneasiness in my chest. This time I did faint and passed out. They took me to the local clinic. They determined that it seemed like maybe it was because of dehydration from moving from the United States to Mideast in the middle of the summer. However, the same thing happened again a week later. This time they decided to set me up, and I went and saw a cardiologist in Abu Dhabi. Believe it or not, the Cleveland Clinic, the famous American Cleveland Clinic, has a center in Abu Dhabi. So the cardiologist there got his hands on me, interviewed me about my symptoms, ran a series of tests, got other disciplines involved, endocrinology, oncology, neurology. They all did their own tests. They couldn't quite put together what was going on. The cardiologist conferred with one of his cardiologist peers back here at the Cleveland Clinic, United States, and they said, well, perhaps he has this rare disease called amyloidosis. So they did some preliminary tests on me. The test results came back and suggested that it could possibly be the case that I had amyloidosis. He advised me that that they couldn't treat me over there. They didn't have the resources to do so. So he sent me back to see Dr. Rodney Falk at the Brigham and Women's Hospital in Boston, and his peer, Dr. Sarah Cuddy, who I know registered for this webinar. So Sarah, if you're out there, hello. They did their own series of testing and confirmed not only did I have amyloidosis, but I had the hereditary type, the type specific to people of Irish descent. So I started my disease treatment in late April of 2019 on patisiran. The treatment showed positive results. I made a decision about half a year later to try to resume my career. I did so. I attempted to resume my career, but it did not work out because of the disease, the fatigue and whatnot from the disease. I wasn't able to resume my career. So I had to stop working. However, I identified that provided me with 3 opportunities. The first opportunity, personal in nature, had I not returned from overseas to seek treatment, I never would have met my girlfriend, who is now my wife, Robin, and is my caregiver, and helps me go on when I go on to all my speaking engagements for amyloidosis. So that's just an awesome story that came true for me. The second opportunity, I had to reinvent myself. I could no longer work. I could no longer do the physical activities that I had done prior. So lo and behold, I found out that I had a knack for drawing and doing artwork. So I'm now, I guess what you call it, accomplished amateur artist. So life brings you down a different path, and both just awesome, life-changing opportunities for me. The third opportunity was that, having had previous public speaking experience in my teaching career, I identified that I had an opportunity here where I could give back and try to help promote and bring about positive change in the amyloidosis community. So I'm now part of what's known as the Amyloidosis Speakers Bureau, we go out and speak to medical students and residency students. So anybody out there that's listening that's part of a medical teaching institution, if you're looking for a speaker on amyloidosis, please reach out to the Amyloidosis Speakers Bureau. So that's my story. I am still on. I had 75 infusions of patisiran, and I have recently swapped to vutrisiran. That's my story, and I'll rejoin now with Dr. Joban in the Q&A session.
That was amazing, Sean. What an incredible journey. I mean, you had to go all the way to Abu Dhabi to figure out what was going on, but that's a good trip. That's a good detour. I like it. I like it. Thank you so much for sharing your story and giving us so much insight. We're going to go ahead and move to the Q&As. There are a lot of questions from you guys. Most of them do seem to be mostly medical in nature, so we'll go through these, and then if we have any extra time, we do have some pre-vetted questions that we feel would be helpful for the audience, so we will try to get to those as well. First of all, Richard Collins asked Dr. Vaishnav, what is an example of a beta blocker?
Yeah, of course. Thanks for asking. Beta blockers are specific medications that are beta blockers include metoprolol, carvedilol, bisoprolol, and these are excellent heart failure medications. And as I mentioned, for non-amyloid heart failure, have overwhelming evidence of survival benefit. Other uses include rate control for atrial fibrillation. That may be another indication for beta blockers. So beta blockers in amyloid are, I think, at this point controversial in terms of whether or not there's overt benefit or harm, for that matter. So in terms of my approach, I typically, especially if someone has a sort of a normal squeeze, a normal ejection fraction with amyloid, I don't aim to start a beta blocker. But as an amyloid patient, you may be on a beta blocker. For example, if you have difficult to control atrial fibrillation or something like blockages or ischemic heart disease. So you may have another indication for a beta blocker that's not necessarily amyloid related.
Perfect. Thank you so much. I hope that answered your question, Richard. The next question, Henry Leibling asked, how is AL different or related to an enlarged heart? Yeah,
great question. So I would say that an enlarged heart is kind of a broad description of what can happen in the setting of heart failure. There are a lot of different flavors of heart failure. One flavor of heart failure is what we call an enlarged heart, where that heart cavity becomes big and wide and baggy, and is what we call dilated. That is very different from amyloid heart failure, where the heart muscle actually becomes thick and stiff and narrow. At the end of the day, amyloid deposition can cause an increase in heart mass, and it certainly can cause heart failure. But it's different from those other types of heart failure. Many causes of the dilated heart failure, like ischemic heart disease, is a common one in the US that actually causes the heart to become big, baggy, and enlarged.
Perfect. Thank you for that. The next question is from Alan, and he asks, is there a current alternative to, is it Vyndamax?
Vyndamax, yeah. Thank you, Mr. Van Prague. So right now, Vyndamax is the only FDA-approved treatment for cardiomyopathy. That said, as I mentioned, and as Sean mentioned, there are more medications that have been FDA approved for polyneuropathy that may very well be used to treat cardiac disease or mixed phenotypes. So folks who have hereditary neuropathy with or without cardiomyopathy do have an FDA-approved alternative. Patisiran was mentioned, vutrisiran, eplontersen. These are under the class of silencers. For cardiomyopathy, isolated cardiomyopathy, specifically wild type, non-hereditary, right now we are working with Vyndamax. So and we do expect alternatives soon. So I mentioned acoramidis is under FDA review. And then there are several clinical trials that are kind of ongoing, So we hope for more alternatives very soon.
Perfect, perfect, perfect. And the next question, there was something that you mentioned, Dr. Vaishnav, about a subcutaneous drug. And
Yeah.
someone was asking if you kind of define that subcutaneous
Yeah,
process.
yeah. Thank you. Apologize for not defining that sooner. Subcutaneous is basically an injection under the skin, similar to like if insulin, for example, is a subcutaneous medication, or heparin shots that you get in the hospital. So subcutaneous simply means an injection that goes into the skin. And that's contrasted. So I mentioned Amvuttra or vutrisiran is subcutaneous. That's contrasted to some of the other medications for amyloid, which are actually intravenous, which means, Sean can speak to this, you need an IV. You typically need to, be at an infusion center or at least have an IV, and that goes in the vein. So the newer silencers are able to be given subcutaneously, and in that setting are easier to administer. And Sean, you can maybe speak to that.
Yeah, absolutely. So the biggest thing one of the big advantages is convenience. So I have been with my patisiran, which awesome medication. However, every 3 weeks I had to travel down to, I live about an hour outside of Boston, but you have to travel down there every 3 weeks and basically you use up a half a day when all is said and done to get the infusion. Now it's just every 3 months I get a shot, and it takes 10 seconds and I'm done. So the benefits of the medicines, like I said, I had 75 infusions with patisiran, and I would say that was a lifesaver drug for me. It definitely was a lifesaver drug. And the vutrisiran, I've only had 2 shots so far, but I don't see any difference. I can't feel any difference, with my symptoms or whatnot from it. Seems to be a fairly simple changeover.
That's awesome. Thanks, Sean. Sean, just what advice would you give newly diagnosed patients?
Yeah, so getting this information, this disease information, can be daunting. It's a confusing disease, it's a complex disease, and can be a potentially fatal disease. My advice is take a deep breath, because it doesn't have to be or shouldn't be a fatal disease anymore. All these wonderful drugs that are out now, just great success stories with them all. So for new patients, there's every single reason to be optimistic.
Great, thank you so much. I see that it seems that we have a lot of caregivers on the line. So how has this impacted, Sean, your caregivers or your family?
Yeah, I'll speak to that in 2 parts. First, I am reasonably self-sufficient. I do have I can get fatigued rather easily. I can't really, for instance, today I was working, or yesterday I was working in the garden, and we had to carry bags of dirt up the stairs, and I can't do that. I just don't have the endurance. That's probably cardiac in nature. So I had to get assistance from my wife and my stepson. I know there are other patients that are perhaps less mobile than I am, and the impact on their caregivers can be tremendous. Like I alluded to, my wife Robin, she's been my rock. When I do go out on these speaking engagements, she comes with me. I can't really shuffle myself through the airport with my luggage quite as good as I used to, so she helps me out with that. The biggest thing I guess she has to deal with, and she takes it lightly, but I think, I think it's significant, and I appreciate it, is this disease from day to day, you don't know what type of day you're going to have physically. And so there's a lot of unexpected on a daily basis. And she has to, and all the caregivers have to be aware of and have to deal with that.
Thank you. That's a great
The other
answer.
thing, the other thing I'd like to say on this caregiver subject. So the caregivers are not only my wife, but my other genetic family members, my siblings. Again, so the disease is genetic in nature, right? So it's gonna. When I found out I had this, it greatly affected my family. I'm one of 6 siblings. My other living, unfortunately, I've got 2 deceased siblings, but their causes of death have nothing to do with amyloidosis. My living siblings got DNA tested. Thankfully, none of them carry the mutation. So everyone downstream of them is off the hook. So I know they're not caregivers. Well, they are caregivers. My siblings are caregivers, so that's why I'm tying it to this question. The other angle to that is I've got 2 children from my first marriage. I can tell you that one of the 2 children does have the mutation. They have no disease symptoms as of yet. They're in their 30s. So they're somewhat young to get that. But so yeah, as far as effect on family, there's that effect as well.
Awesome. Thank you so much for sharing that full hereditary view of the disease and how it can, like you said, affect one sibling and not affect the other 5, but still be passed to the children. That's quite a disease. Dr. Vaishnav, one of the questions here has to do with heart transplant, and it asks, can you get a heart transplant due to heart failure caused by amyloidosis and get amyloidosis in the new organ? Also, could you get it in another organ, like in the liver?
Great question. Absolutely. Amyloidosis that leads to end-stage heart failure is an indication for heart transplant. Whether or not heart transplant is an option will very much depend on your case. And I'll say, just sort of anecdotally, in the patients that I care for, the most common reason heart transplant may not be an option is age, because this does tend to be a disease that affects elderly individuals, specifically wild-type TTR. But heart transplant is done and can be done for advanced stage amyloidosis at sort of select centers. The amyloid could recur in the transplanted heart, though amyloid tends to be a slowly progressive process and takes years to sort of develop and deposit in the heart over time. And it certainly, on that note, can deposit in non-cardiac organs as well. And so I would say there's kind of more and more data coming out about this, but the majority of patients getting a heart transplant or centers doing heart transfer for amyloidosis will begin treatment with the medications I mentioned to try to prevent specifically non-cardiac deposition of the amyloid. So the last thing you want is to go through a major heart transplant and then, God forbid, develop horrible neuropathy or GI symptoms. So one way to prevent the deposition of amyloid after the heart transplant, which may still be produced from the liver, is to start these medications. Historically, heart and liver transplant used to be done for this condition. But with the sort of the advent of disease modifying therapy and with time, that's not as commonly performed.
That's a great answer. And this is the next person's question, but it's kind of the same. Someone asked, can amyloid affect the pancreas, causing type 2 diabetes?
Yeah, I mean, so AL amyloid can deposit nearly anywhere. Pancreas itself, I would say, is probably rare, at least in my experience. But theoretically, AL amyloid can deposit in almost any organ. So that is a possibility. I haven't seen diabetes related to AL amyloid deposition in my practice.
I'd like to add to that.
Oh, go ahead.
Yeah. So we recently discovered that I've been getting bouts of hypoglycemia, and they've been getting more frequent over time. And there's one theory that perhaps, so my GI symptoms cause my stomach to release its contents into my lower GI tract kind of prematurely. And what that can do, that triggers a hormone to tell your pancreas to release insulin. And the thought is perhaps that is what's causing my hypoglycemic attacks that I'm having. We don't know 100% for sure, but boy, I mean, this disease is so complex. It can have primary and secondary effects on everything that it's definitely something that we're keeping an eye on and trying to combat.
It sounds scary, honestly, but it also sounds like there's a great deal of care that's taking care of these patients, and in many different ways to treat these things that come up. One of the questions for you, Sean, was how does your insurance handle like the shifts in medication and some of these symptoms that come up that you need new medications for? Is the insurance generally cooperative?
That's a great question, because I am fortunate enough that I have really good private commercial insurance. I know there's a lot of amyloidosis people in the community that aren't quite as fortunate, and the medication is extremely expensive. Expensive enough where most people wouldn't be able to afford maybe even one dose of it. But I've had a very easy time, and it's all a product of the great job that the facility that I'm treated at does interacting with insurance company. And my when I first went on patisiran, the approval was immediate. And when I swapped from patisiran to vutrisiran back in December, that was very seamless and bumpless transfer for me. So I was fortunate, but I will add that it can be a tremendous challenge for other patients in the community.
Okay. And we do have several more questions. These questions we will be able to send out to you after the session's end. We're going to take one other question, and then we're going to wrap up. We talked about amyloidosis not really presenting until later in life, but I believe it's Naya said she's in her early 30s and learned about their hereditary TTR mutation due to a health screening. Any recommendations, Dr. Vaishnav, for how often to monitor with echoes?
Yeah, it's an important question, and I would say kind of increasingly being diagnosed. So if you are a patient afflicted by hereditary amyloidosis, there is generally speaking a 50% chance that gene can be passed on to family members and children alike. When someone is diagnosed with hereditary amyloidosis, we generally recommend what we call cascade screening, which is a mechanism to find out if you are at risk for this disease, oftentimes before you may even have symptoms. Cascade screening, there are kind of different guidelines, but I would say in general, given that this is sort of an age-related phenomenon, we would definitely recommend if you're within 10 years of your family member's diagnosis, or above the age of 50 is another cutoff. But it is being done. It could be done at a younger age, or someone did a 23andMe and came up and this gene came back positive. So the situation mentioned is one that I've come across and evaluated patients for. In terms of screening for asymptomatic family members, if you are gene positive, so if you're gene negative, you don't need to be screened. If you're gene positive, I would say when you're in that age range that I mentioned, then from a cardiac standpoint, certainly you should be screened for any heart symptoms or structural heart disease. So electrocardiogram and echocardiogram may be performed. And the frequency could vary based on your family history, but I would say similar to other genetic cardiac conditions, tends to be in that 3 to 5 year range for repeating, though it will be case by case depending on your age and your family history. And that's from a cardiac standpoint. Now, polyneuropathy can affect patients at a younger age. And so if your family history or your genes suggest more of a neuropathic phenotype, then we would also recommend screening for neuropathy as well at different frequencies. So the screening will depend on your family, what gene we're dealing with, your family history, and your age.
Perfect, perfect. Thank you so much, Dr. Vaishnav. Thank you again, Sean, for your input and for telling us your story. As we said, all the questions that have not been answered, they will be available. I believe they'll be sending those out. But I also want to remind you guys to complete the evaluation. It'll be sent via email following the webinar. Your feedback is super, super important to us. So please make sure you get that filled out so that we can continue to bring you these type of productions that really truly get to the heart of your matter. And we will conclude with once again thanking our sponsors, AstraZeneca, BridgeBio, Intellia Therapeutics, and Pfizer. Thank you all so much for allowing us to come into your homes today. This is Brittany Clayborne, Chair of the Patient Committee for the Heart Failure Society of America.
Have heart failure with unresolved symptoms? It may be time to see the bigger picture. Heart failure and seemingly unrelated symptoms like carpal tunnel syndrome, shortness of breath, and irregular heartbeat could be something more serious, called ATTR-CM, a rare, underdiagnosed disease that worsens over time. Sound like you? Call your cardiologist and ask about ATTR-CM.
For me, it honors my dad. I'm paying it forward to make a difference in people's lives, and you know, why are we here on the planet, right? You know, to resolve issues and to make a difference, and ultimately we're all connected, we're all one. So for me, it's anything I can do to help make a difference and encourage people to get tested, doctors to get educated, is really important to me.